term implies, acute kidney injury means there is a acute reduction in the kidney function. So it's something to do with the kidney function. So when you say acute kidney injury, you are talking about kidney function. And so that's an important thing you need to remember. And so it's acute, so it has to happen over a short period of time. So there are various definitions because over the years, people have tried to, come up with various, terms to denote what is acute kidney injury. Earlier, people used to say this is acute renal failure. So like that. So, but now the new term that is used is acute kidney injury. That's because injury means that there is a potential chance of improving, whereas failure generally implies that there is no chance of recovery. So that's why this new term is preferred. And also people have used various definitions in defining acute kidney injury. So now we have kind of come to a very uniform definition, which was devised by KDIGO. It's a group involved with, developing, guidelines for kidney diseases. And they have come up with this new definition. So according to that, acute kidney injury is defined or diagnosed based on two main criteria. One thing is on the basis of serum creatinine. The other one is on the basis of urine output. So if there is an increase in serum creatinine by more than 0.3 milligrams per deciliter within a period of 48 hours, or if there is an increase of equal to or more than 1.5 times the baseline serum creatinine within 7 days, we call that somebody is having acute kidney injury. So these are the creatinine criteria. In addition, if somebody has reduction in urine output less than 0.5 milliliter per kilogram per hour for more than 6 hours, then also we can diagnose acute kidney injury. So you need to fulfill either of these to make the diagnosis. So you don't have to have both. Either it has to be a rise in serum creatinine or a reduction in urine output. Why you need both or one, two criteria to diagnose acute kidney injury is beyond the scope of this lecture. If you are interested, you can read about it and find out why you need serum creatinine and urine output, two different criteria. However, this is the general criteria that we are using to diagnose acute kidney injury, and you need to know this. This is the most important part of the lecture because we need to know what is acute kidney injury. So it's a functional deterioration of the kidney, and it happens over a short period of time, and it is defined on the basis of reduced urine output or increase in serum creatinine. Then KDIGO definition is the top row that I have given, stage 1. So in addition to that, they have gone on to categorize according to the severity of acute kidney injury to different stages. You have different stages. So you have stage 1, 2, and 3 based on the rise in serum creatinine and the drop in urine output. So you can go through this, and so you don't really need to know the stages, but you need to have an idea how they are being categorized. So why are we talking about acute kidney injury? So one reason why we are talking about it is very common. So generally 7% of all patients admitted to hospital are known to have acute kidney injury, and up to 25% patients admitted to ICU are having acute kidney injury. So it's quite common, and sometimes this acute kidney injury can be severe enough to require dialysis. So that is another problem because it needs certain additional treatment. And even with a slight increase in serum creatinine, that means even in AKI stage 1, there is increase in mortality. So that is the other reason why you need to know about acute kidney injury. So the next most important thing is to understand what are the types of acute kidney injury. So classically, we kind of categorize acute kidney injury into 3 main broad groups: pre-renal, intrinsic, and post-renal. So pre-renal generally means the problem has happened before the kidney. So that means there is some problem with the renal perfusion. Intrinsic kidney injury means, usually I will go into detail in each of these categories in the next few slides. So intrinsic means there's some problem within the kidney. And post-renal kidney injury means there is a problem in the outflow tract, in the urinary flow tract of the kidney. So that is roughly that you need to remember. But now we'll take each one by one. So pre-renal. So essentially pre-renal acute kidney injury means there is no structural problem within the kidney. The poor function of the kidney is related to reduced perfusion of the kidney. So in other words, if you replenish or restore the perfusion within a certain period of time, immediately the kidney will start to work again. So what are these reasons that you can get pre-renal AKI? One reason is if there's a decreased effective intravascular volume. That means there's an intravascular volume depletion. So this can happen due to either total body volume depletion, that is by losing fluid through gut, by, let's say by vomiting or diarrhea, or excessive water loss through the kidney by polyuric conditions, and or if you are losing volume through the skin, like in burns. So then you have a total body absolute volume depletion. But then there's another situation where you can have a total blood volume is normal, but there's a volume redistribution. That means the total body volume is okay, but it is distributed in such a way that intra-arterial volume is reduced. So this happens in third space losses, like in large pleural effusions, intestinal obstruction where the fluid is sequestered inside the bowel. So like that. So the total volume is normal, but they are kind of confined to particular areas. And also in sepsis. So as you know, in sepsis, there is a systemic vasodilatation. So although the total blood volume could be normal, because of the vasodilatation, the blood pressure and the relative volume of within the circulation is reduced. And also in hepatorenal syndrome, it's another condition. You can read about it where you have a volume redistribution. So pre-renal AKI can be due to it's due to reduced renal perfusion. This could be due to absolute volume depletion or a relative volume depletion. Then, in addition to that, reduced renal perfusion could be secondary to reduced cardiac output, such as in acute heart failures and things like that. And also when there's a renovascular disease, like, if there's a block in the renal artery or something like that. Actually, drugs, I would not, although it's mentioned here as pre-renal, essentially what they do is they kind of interfere with the renal autoregulation by interfering with, prostaglandins and things like that. But naturally, we generally put the drug-induced AKIs into a renal category rather than the pre-renal. So although it's mentioned here, it should come under the renal category. Then intrinsic AKI is the next component. So intrinsic AKI means there is some structural damage to the kidney. So I told you that in pre-renal, it's a functional injury. There is no structural damage. But here there is a structural damage. So there are 4 types of structures you have in the kidney. If you know, you are familiar with the anatomy of the kidney. You have the glomeruli, which are here, small structures. And then you have the tubules. Then you have the interstitium between these tubules and the glomeruli, and then you have the blood vessels. So those are the 4 main structures in the kidney. So any of these structures can be affected, and an acute kidney injury can happen. So if there's a glomerular involvement, you can get glomerular nephritis, and then it's cause acute kidney injury. If there's a tubular involvement, you call it acute tubular necrosis, and then you can get acute kidney injury. If there's interstitial involvement, you call it acute interstitial nephritis, who can cause acute kidney injury. And also there are so many vascular conditions which can offend the blood vessels, leading to acute kidney injury. So we'll take one at a time. So the commonest cause of intrinsic acute kidney injury is acute tubular necrosis. So commonest reason why acute tubular necrosis happens is due to ischemia. So, for example, now you have the pre-renal AKI. I told you that in pre-renal AKI, it's only a functional renal injury, that if you restore the volume or the blood supply to the kidney, immediately the kidney will start to work. But if this restoration takes time, and then it's delayed, then there would be permanent structural damage. Not permanent, there would be structural damage to the kidney. So therefore, once that damage starts to happen, then you call it acute tubular necrosis, because usually ischemia, due to renal ischemia, when the pre-renal injury persists, it damages the tubules. So you call it acute tubular necrosis. So acute tubular necrosis is caused by delay in restoration of the volume depletion. So what you need to, so how do you differentiate clinically these two situations is that if the patient is responsive to volume, that means if you give some fluid and the patient starts to produce urine, so that means obviously there is no structural damage to the kidney, it's a functional damage, so that once you give the volume, the kidney starts to work, that's why the urine is coming out. So we call it the volume responsive stage. Similar, on the other hand, if you give the volume, once you develop the structural damage, that is once you develop acute tubular necrosis, even if you give fluids, there won't be immediate production of urine. So then you call it volume non-responsive stage. So acute tubular necrosis, once it develops, it is a volume non-responsive stage. So, but volume depletion is only one cause of acute tubular necrosis. In addition to that, it can happen due to sepsis, because there are so many cytotoxic mediators developed during sepsis, cytokines, interferons, and things like that, and that can directly damage the tubules, leading to acute tubular necrosis. And also toxins such as drugs, radio contrast media, and also snake venom toxins, that can also directly cause damage to the tubules, giving rise to acute tubular necrosis. So acute tubular necrosis can be divided into three categories: ischemic ATN, septic ATN, and toxin mediated ATN. So that is the next thing you need to keep in mind. And but the commonest is the ischemic ATN, which is a progression of pre-renal AKI. So so this is how phases of ischemic epithelial tubular injury happen. So you have the pre-renal AKI when there's a drop in GFR, and then you have the these are the functional stage. This is the functional stage, and then once if you kind of reverse the injury at this point, the kidney will recover. But if it is delayed, then you have an initiation phase, extension phase, causing further structural kidney damage. So this is the structural part, or what you call the acute tubular necrosis part. And then as long as the injury or the underlying problem remains, you have the maintenance of the injury. And then after that, you have the recovery phase. So acute tubular necrosis is a recoverable condition. Then moving on to the next component, I told you that there could be tubular causes, and then there are interstitial causes. So this is classically known as acute interstitial nephritis. So commonly acute interstitial nephritis is caused by two main groups of conditions. One is it could be secondary to drugs. The other one is due to infections, such as leptospirosis. So drugs are common drugs which can cause, so most drugs can cause acute interstitial nephritis, some commonly, but some rarely. So common drugs which are associated with acute interstitial nephritis, you need to know: non-steroidal anti-inflammatory drugs, diuretics, antibiotics, and rarely proton pump inhibitors. So these are some of the drugs which can cause acute interstitial nephritis. The common infections in our setting which can cause acute interstitial nephritis is leptospirosis. In addition to that, there are other infections, viral, bacterial, fungal, parasitic infections which can cause acute interstitial nephritis. So now we spoke about tubular causes, we spoke about interstitial causes. Now we will talk about glomerular AKI. Now we have already dealt with this in our in my previous lecture on glomerular syndrome. So if somebody gets a glomerular disease and develops AKI, that's called a glomerular AKI. So it's a glomerular nephritis. So all glomerular nephritis come under this category. So as we discussed in our previous lecture on glomerular syndromes, several glomerular syndromes can be affected with acute kidney injury. The main one is rapidly progressive glomerular nephritis, where the kidney, you have learned that the kidney, there are crescents within the kidney glomeruli, and then you get acute renal shutdown. So the common causes of rapidly progressive glomerular nephritis are post-infectious or infection-related glomerular nephritis, vasculitis, anti-glomerular basement membrane disease, lupus nephritis, and IgA nephropathy. So these are some of the conditions which can give rise to rapidly progressive glomerular nephritis. In addition to that, people even with nephritic syndrome, where the disease has not yet moved or severe enough to be categorized as a rapidly progressive glomerular nephritis, even then you can have mild acute kidney injury. So we have spoken about glomerular, tubular, and interstitial causes, and the final one is vascular causes. So sudden vascular problems. We are talking about intrarenal blood vessels. In pre-renal AKI, we are mainly talking about main renal artery before the artery enters the kidney. But here we are talking about blood vessels within the kidney. So various conditions can kind of damage blood vessels or block the blood vessels within the kidney, such as cholesterol embolism, hemolytic uremic syndrome, malignant hypertension, scleroderma. So I will not go into detail as to each of these conditions. They are by itself a separate topic. But you can, if you are interested, you can read as to how each of these conditions can lead to acute kidney injury. Okay, now we have spoken about pre-renal AKI, intrinsic renal AKI, and now we will move on to the post-renal AKI. So as I told you, post-renal AKI means that there is a block to the outflow tract of the kidney. So that means there is a problem with the ureter, or block in the ureter, or in the bladder outlet. So essentially, you have to develop acute kidney injury, both kidneys have to be blocked. If it has one kidney working, still you don't get acute kidney injury. So how do you get both kidneys obstructed? Either it has to be at the level of the bladder outlet. So it can be due to pelvic tumors or prostatic enlargement or prostatic cancers. Or if it is ureteric level obstruction, it has to be bilateral. So you can have bilateral stones, bilateral strictures or tumors obstructing the ureters. Okay, so we have now spoken about or discussed about the various categories or groups of AKI. Then there are other important concepts that you need to remember. So I told you that AKI is defined based on the rise in serum creatinine or a drop in urine output. So why you need two criteria? I told you that you need to read, but this is one of the reasons. Not all AKIs are associated with reduced urine output. Sometimes you can have normuric AKIs. Sometimes it can be associated with, so these are also known as non-oliguric AKIs. And you can have oliguric AKIs or anuric AKIs. So that means if somebody has a normal urine output, doesn't mean that he is not having AKI. So urine output may not really reflect the kidney function in some situations. So therefore, so it's important to recognize whether somebody is oliguric, anuric, or non-oliguric. Essentially, people who are non-oliguric having AKI, those types of AKI has a good prognosis compared to people who are oliguric or anuric. That's all you need to know. And also, so that is prognostically. At the same time, presence of oliguria or not will help you to understand the underlying etiology. For example, if somebody is oliguric, they are more commonly associated with underlying obstruction or pre-renal AKI. If they are non-oliguric, they are commonly associated with intrinsic renal injuries like nephrotoxic ATNs, acute glomerular nephritis, or acute interstitial nephritis. So what you need to remember, if it is pre-renal or post-renal, usually renal urine output is low. So they are usually oliguric or anuric. Whereas if it's intrinsic renal, sometimes you can have normal urine output. Right. So having discussed about the various causes or categories of causes of AKI, now moving on to evaluation of AKI. So this is what is important to you. When you go to the wards, and when you work as doctors, when people come with symptoms and signs suggestive of acute kidney injury, how would you evaluate them? So, and why do you want to evaluate them? What are the main objectives that you need to achieve? So, one of the first things that you have to think is if this patient is having acute kidney injury, or is this chronic? Because I don't know whether you have had the lectures on chronic kidney disease, but as you know, kidney diseases are two types. One is an acute type, one is a chronic type. So obviously, chronic type is a different type of disease where it's usually irreversible and it is a long-standing thing. Whereas acute is a short-lasting problem, and it is a mostly reversible situation. So it's important to differentiate these two conditions. And usually lab values do not discriminate between acute versus chronic. Both will tell you that the creatinine is elevated. But generally, if somebody is oliguric, it generally tells you that they are having acute renal injury rather than chronic kidney disease. In addition to that, there are other clues to chronic kidney disease, such as pre-existing risk factors for CKD, like hypertension, diabetes, increasing age, vascular disease. Then if they are having frank uremic symptoms like fatigue, nausea, anorexia, pruritus, hiccups, and things like that, generally, they are having chronic kidney disease, because at terminal stages of chronic kidney disease rather than acute. And also, if you do an ultrasound scan, if the kidneys are small and echogenic, they are more in favor of a chronic kidney disease. So this is an important area that you need to know, because this is one of the commonest areas that we ask questions from you in the exam, how to differentiate acute from chronic kidney diseases, right? So you need to know this. So as for any disease, there are several steps that you need to follow when you are evaluating a patient with acute kidney injury. So first thing is obviously to take a good history, and then physical examination, and also you need to look at their observation charts, their urine output, blood pressure, and things like that. And then also the key important thing is to check their volume status. So I will go into detail as we move on. And you have to do two things when you have a renal suspicion of acute kidney injury. You have to order a renal ultrasound scan, and also you have to look at the urine. Urinary indices are not that important, but I think the top four things are the more relevant things. So history. So the commonest cause of acute kidney injury is pre-renal. So that is the most common situation, because there are so many patients with dehydration, bleeding, burns, and people with sepsis, so that they have risk factors for pre-renal AKI. So it's important to kind of ask in the history for these conditions, like diarrhea, blood loss, vomiting, overdiuresis, things like that. And then you have to look for. Now, I told you intrinsic renal injuries, there can be various causes: drug exposures, contrast exposure, infections, sepsis, and also certain toxins, snake bites, rhabdomyolysis, hemolysis, and things like that. So based on the individual underlying list of causes, you need to ask about these during the history taking. Then also you need to talk about their symptoms related to possible underlying causes. Like, for example, if you are thinking of a vasculitis or an autoimmune disease which can lead to glomerular nephritis, you need to ask about fever, rash, joint pains, myalgias, and things like that. Then if you're thinking of heart disease which could lead to pre-renal AKI, you need to talk about orthopnea, paroxysmal nocturnal dyspnea. If you think of good pastures, you can think of hemoptysis, preceding bloody diarrhea. If you're thinking of hemolytic uremic syndrome, preceding pharyngitis and skin sepsis, if you're thinking of post-streptococcal glomerulonephritis. So depend. It's a matter of just depend. Having the list of causes so that you can you have to look at the precipitating factors. Then, as I told you, that you need to check their urine output just to confirm the diagnosis as well as to identify what type of renal injury they have. So as I told you, this I've already told. So if there's abrupt anuria, it's more in favor of obstruction, acute glomerulonephritis, or sudden vascular catastrophe like a renal artery thrombosis or something like that. So these are some of the things. And you had a PBL on hematuria. So you can need to know whether it's a painless hematuria or painful. Based on that, you can differentiate what type of underlying cause it is. So that's the history. Then physical examination. The key thing about physical examination when somebody with acute kidney injury is to assess the volume status. So volume status is very important because that will tell you whether somebody has got pre-renal AKI or whether this is more than just pre-renal AKI. So how do you check the volume status? So there are clinical signs that you go by. You can look at the neck veins and check whether there's jugular venous pressure, whether it's elevated or not seen. If there's edema, whether there is a blood pressure reduction or there's a postural drop in blood pressure, and also you can look at the skin turgor, mucous membranes, capillary refill, and things like that. So this will tell you whether somebody's volume depleted or having a normal volume status or having a volume overload. But it's important to realize that clinical evaluation of volume status may not necessarily be accurate. For example, somebody may be having edema due to low albumin levels, but at the same time they may be intravascularly volume depleted. So only way to find out sometimes is to give a volume fluid bolus. I will tell you that later, to see whether the patients are volume responsive, or in other words, they are in the pre-renal phase or not. So in addition to volume assessment in physical examination, you have to, depending on the possible underlying causes, you have to look for various signs. So they are all here. For example, malar rash, we are thinking of SLE, petechial rash, we are thinking of Henaption line purpura, and things like that. Right. So having looked at having gone through the history and then the examination, and the third component is investigations. So any condition we are investigating to fulfill three main things: to confirm the diagnosis, to identify the underlying cause, and to look for complications. So as I told, the crucial thing about acute kidney injury, it's you have to confirm the diagnosis. So essentially, you have to know what the serum creatinine is. So most of the time, so I told you from the baseline, there has to be a rise in serum creatinine, but the problem is most of the time, we don't have a baseline serum creatinine. So sometimes you might have to frequently measure their creatinine levels to see whether there is a rise. So sometimes on admission, creatinine can be considered as the baseline, and then from there you can see whether there is a rise in serum creatinine. And so that is a confirmation. So you have to check the serum creatinine, and also obviously you would have looked into the volume urine output. Then in addition, there are certain investigations you would do to identify the underlying cause. I told you that there are two things that you need to do for any patient suspected of having acute kidney injury, two investigations. One is having a look at the urine. The other one is the ultrasound scan. So why do you check the urine? Is to check whether with the urine dipstick to see whether there is blood and protein in the urine. And then you do the urine microscopy to see whether there are dysmorphic red cells or red cell cars. So I have taught you all this in the glomerular nephritis lecture, why you want to check these. Then why do you need the ultrasound scan is simply for the reason of excluding obstruction. Because if there's an obstruction, you develop hydronephrosis and hydroureter. So that is what you need. You are doing the ultrasound scan. But in addition to that, you can get other clues to AKI based on the ultrasonic appearance. But the main reason why you want to do the ultrasound is to exclude obstructor, or in other words, excluding post-renal AKI. So the important things to us, there are certain other investigations. So the best way to identify what is the underlying cause, if you don't have obstruction, if you don't have a pre-renal cause, then you have to think of intrinsic renal causes. So the best way to identify intrinsic renal causes is to do a renal biopsy, to look at the histology. Then you will know exactly whether there is acute tubular injury, or whether there is a interstitial nephritis, or whether there is glomerular nephritis, things like that. But obviously that will take some time. So while you are waiting, you can check for these other markers of various acute renal injuries. So as I told you, the ultimate test or the investigation would be to do a renal biopsy, but we don't normally do a renal biopsy. Or whether they have moved into a volume non-responsive state. So how will you differentiate is by giving a fluid bolus. So this is the best way to find out whether the patient is in volume responsive phase or in the volume non-responsive phase. So what you do is you give small volume boluses. Example, 250 ml of 0.9% sodium chloride over, shall we say, over half an hour. So it has to be a very defined volume over a defined period. And then you look at how the patient responds. So either, if there is an improvement in urine output, the patient is in the volume responsive stage. If the patient is no improvement in urine output, then you have to look at the volume status of the patient to see whether the patient is still in the volume depleted stage or whether the patient is now developing signs of volume overload. If the patient is still, you feel if they are volume depleted, you can repeat the bolus and see whether there's improvement in urine output. On the other hand, if there are signs of volume overload like edema, bilateral basal pulmonary crepitations, elevated JVP, then when these signs develop, then you know that the patient is now developing volume overload, and probably the patient is not responding to volume resuscitation or volume boluses. So probably he is in the volume non-responsive phase of the acute kidney injury. So then you have to stop giving extra fluids, because otherwise you will push them into fluid overload. So that is how you do it. So which fluid you use, it doesn't really matter. But usually what we use is isotonic crystalloids like saline, 0.9% sodium chloride, which is commonly available in the wards. And so that is how you ensure optimal renal perfusion. Sometimes just in giving fluids will not be adequate. They have low blood pressures due to sepsis and other vasodilator mediators. So in that situation, you might have to use vasopressors to treat hypotension. So the best agent that we can use in this situation is norepinephrine. But other vasopressors also can be used, like vasopressin, dopamine, adrenaline, or dobutamine. So once you one important thing is to ensure optimal renal perfusion. So you can do that by giving fluids or using vasopressors. Then you have to treat the underlying cause. So this is self-explanatory. So if somebody has got acute kidney injury due to drugs, nephrotoxic medications, you need to stop them. If it is somebody has got AKI due to sepsis, you need to treat with antibiotics. And then you have to specifically manage glomerulonephritis, maybe with immunosuppression. And if somebody has got obstruction, you have to relieve the obstruction. So this is straightforward. Then moving on to complications. So I told you that there are several complications we develop. One of the main complications is if you become over-aggressive with volume replacement, you can develop volume overload. So in order to avoid that, the important thing is you need to make careful maintenance of fluid balance charts. And also in the early stages, once they develop early signs of fluid overload, you can use diuretics. And you can use oxygen, CPAP, if they are having features of pulmonary edema. But most of the time, if they are not responsive at this stage to various treatments, we might end up needing renal replacement therapy to correct the volume overload. Then, so one of the other complications that can develop with acute kidney injury is hyperkalemia. So this is an emergency. So you should treat it as an emergency if the potassium is more than 6.5 or if there are ECG changes associated with hyperkalemia. So I am not going to go into detail of what are the ECG changes you get. You need to know that. So there are important considerations when you have to treat for hyperkalemia. First and foremost, you need to give cardioprotective drugs like 10 ml of 10% calcium gluconate over 2 to 5 minutes to reduce the sensitivity of the heart to increase potassium. So in other words, it will not reduce the potassium level in the blood, but it will protect the heart from the hyperkalemia. So that is the most important first step in managing life-threatening hyperkalemia. The next step are to reduce the potassium. So there are two ways you can reduce potassium. One thing is to reduce, let the potassium taken up by cells. So increase the cellular potassium uptake. So there won't be reduction in the total body potassium. There is a shifting of body potassium from the intravascular compartment into intracellular compartment. So this can be achieved by giving insulin. So you give 10 units of soluble insulin But just giving insulin, what will happen is it will push the potassium into the cells, but at the same time, it will drop the sugar. So in order to prevent hypoglycemic effect of insulin, you have to also co-administer 50% dextrose along with the insulin. So you can give it over 10 to 15 minutes, and then you have to repeat the potassium level. So there are other drugs which can be used, such as beta-2 adrenergic agonists, such as salbutamol or terbutaline. So you can nebulize them with these agents. What you need to remember is that you have to use a higher dose to nebulize these patients, because this is not the treatment effect of the drug, it is the side effect you are trying to achieve, the hypokalemic effect. So therefore you have to use a higher dose. So if for asthma nebulization, you might use about 5 milligrams, but for treatment of hyperkalemia, you might have to use about 20 milligrams. Then correction of acidosis by giving sodium bicarbonate also will help the potassium to move from the intravascular compartment into the intracellular compartment. But usually it's generally effective if the serum bicarbonate level is less than 16. And the other problem with giving sodium bicarbonate is sometimes they can push you to volume overload, especially with Anuric AKI patients. So therefore, you have to be careful in giving sodium bicarbonate in these patients, and you have to give only if there is no evidence of volume overload. So these are the treatment strategies you can use to reduce the intravascular potassium. In addition, but they are just shifting the potassium from intravascular space to intracellular compartment. So after some time, these drugs won't work after about 48 hours, because then the intracellular potassium will start coming back to the intravascular space. So the best way to treat the hyperkalemia is to reduce the total body potassium. So this can be achieved by various mechanisms. One thing is by giving diuretics, loop diuretics, because loop diuretics block the sodium potassium 2 chloride co-transporter in the thick ascending limb of the loop of Henle. So it prevents absorption of potassium. So it will help the excretion of potassium from the kidney. But if the urine is not being produced, this is not going to be useful. Then you can use only way to remove potassium from the body in that situation would be to do renal replacement therapy. Potassium binding resins also can be used orally, which bind with the dietary potassium and prevent them from getting absorbed. But generally, they are not used in the acute setting, because it will take at least 24 hours for these binders to work. There are newer potassium binding medications which has come to the market, but they are not really available in Sri Lanka at the moment. Just remember, you can just, if you are interested, you can, you should know, there's a drug called Patiroma, and there's another one called sodium zirconium cyclosilicate. So these drugs, just remember, there are newer drugs which are coming into the market, which are available in other countries, which are not yet available in Sri Lanka. Okay, then we have dealt with volume overload, hyperkalemia, and now how do you treat acidosis? So acidosis, you can, if it's mild acidosis, sometimes you don't have to do anything. It will automatically correct with volume resuscitation. But if they are severe acidosis with a pH of less than 7.2, then you might have to give IV or oral sodium bicarbonate. And but as I told you, the problem with giving bicarbonate is it can develop hypernatremia and volume overload. So in that situation, you might have to consider renal replacement therapy. So finally, why or when you need renal replacement therapy in acute kidney injury? So if these complications develop and if you cannot manage them with medications, medically, then that is the time that you have to consider renal replacement therapy. So especially if you develop uremic encephalopathy or pericarditis, or if you develop pulmonary edema, hyperkalemia, acidosis, which are resistant to medical therapy, that is the time that you need to offer renal replacement therapy. Drug overdosage, like lithium toxicity, also can cause acute kidney injury. In that situation, also you can use renal replacement therapy. In addition to treating the acute kidney injury, it will help to remove the lithium from the blood. So, just a brief kind of overview about renal replacement therapy in AKI, types of renal replacement therapy. You will have another lecture on CKD, and there also you will be taught about renal replacement therapy. But the important thing about acute kidney injuries, you can use same intermittent hemodialysis that used for chronic kidney disease patients here as well. But in addition, you can use continuous renal replacement therapy. That is where so you know that intermittent hemodialysis, you generally connect it to a dialysis machine, and the treatment is given over a short period, over 4 hours, and then you are disconnected. So it's a very kind of artificial process. It doesn't replicate what a kidney does over 24 hours a day. And usually the patients have to be hemodynamically stable with a good blood pressure to undergo this type of dialysis. Whereas sometimes in patients with acute kidney injury, if they are having sepsis, their blood pressures are low and they are hemodynamically unstable. In that situation, they are not suitable for acute hemodialysis, intermittent hemodialysis. In that situation, you might have to consider a type of dialysis called continuous renal replacement therapy, or known as CRRT, where the dialysis is done bedside in a ICU setting, where the patient is connected to the machine over 24 hours. So it's a continuous process. So that is continuous renal replacement therapy. And there are hybrid therapies. Sometimes you use machines to do longer sessions than the intermittent hemodialysis, let's say for 6 to 8 to 12 hours, but not a continuous thing. So it's something in between, which is called slow low efficiency dialysis. So these are some of the modalities that are available for treating acute kidney injury. Then also we have our peritoneal dialysis, which is not done commonly these days. I don't know whether anybody has seen peritoneal dialysis being done in the wards. But it is now coming back into practice in treating acute kidney injury. What we used to do was to put a rigid peritoneal dialysis catheter into the peritoneal cavity and then connect it to a peritoneal dialysis container and do hourly cycles of peritoneal fluid going into the peritoneal cavity and then removing it on hourly basis. And this is just an inward procedure, generally done over 48 to 72 hours. But the problem with this procedure was that, people can get infections in the peritoneum. You can get peritonitis. And also these rigid catheters can damage peritoneal intra-abdominal organs when you are inserting, because they are done blindly. But so now we are using flexible catheters. So, when you learn the CKD lecture, you will be taught about continuous ambulatory peritoneal dialysis, so CAPD, where they use flexible catheters to dialyze people long term. But same catheter can be used in the acute setting to dialyze people with acute kidney injury. So those disadvantages of rigid catheters, like intra-abdominal organ damage, is minimized, and also because these peritoneal dialysis catheters they have a cuff, so which will prevent infections from migrating from outside into the peritoneal cavity. So therefore, infection risk is less. So therefore, peritoneal dialysis is now coming back as a modality to be used in acute kidney injury. So you need to just have some general idea about these things. You don't need to know a lot. Okay, so that is about renal replacement therapy. I think we'll stop there, because then you have two conditions which can give rise to acute kidney injury: rhabdomyolysis and also aminoglycoside-induced nephrotoxicity. which also are given at the latter part of this lecture. So I will, upload this to the LMS, so you could go through those additional cases also. But generally, I think it's enough for you to know this much. And if you know this bit, that would be enough for the time being. So I can briefly let you ask any questions if you have any, before we wind up the session. Anybody want to ask any questions? Anything unclear or any area that you want me to stress on? Yeah, somebody has asked a question on the chat. Are there only cellular CARs in AKI, or can they have a granular CARs as well? Yeah. So as I told you that classically you get these red cell CARs in glomerular nephritis. So that is the indicator of glomerular nephritis. But there can be other CARs in urine, like granular CARs, epithelial CARs and things like that. They might indicate other sites of renal injury, like tibular injury and things like that. So presence of CARs can sometimes indicate intrinsic renal injury. It is indicative of glomerulonephritis if you have red cell CARs. Okay, if there aren't any other questions, we'll stop it there. So I'll meet you again on Friday for the other two lectures, case-based discussions. So basically there we'll be talking about how we apply the things that you have learned during the module into actual clinical scenarios. So there also even we can touch upon some of these issues. So, okay, so we'll stop there.
Thank you, sir.